This session is on well-being, and we're joined by Professor Dave for this important session covering the importance of well-being in the NHS. Doctors in Distress was created to raise awareness on the value of medical professionals, health and well-being, and the need to care of those that care for us. So I'm just going to pass it to you, and you can start the session when you're ready.
Well, thanks everyone for inviting me. Thanks to Rajiv and team for organizing such a wonderful session. And if you give me 2 seconds, I'm going to try and start sharing my screen. So there we are. Hopefully, are you able to see my slides? If someone can just say yes to me.
Yes.
Okay. I won't be able to read the text box, so apologies for that. That's my Twitter handle if anyone wants to tweet about the session. So I just wanted to start with where I started. And I think I started my journey in Grant Medical College in Mumbai, in India, which is one of the oldest medical schools. And as you can imagine, in a crowded city like Mumbai, it was quite an experience. An outpatients clinic would normally be full of about 150, 200 people. So early in the morning, people would crowd and start milling around. And very early on, I kind of realized that the level of joy that you got from actually helping other people. But what I also realized is that your science was only as good as it was we were able to use it to help other people. And so I think that whole idea of wanting to make things better for people is woven into the idea of medicine. And that is so ingrained, but I don't think we think as much about helping ourselves. And I think that bit of the kind of wiring just does not take place. And I think my talk is really about that today, is to see, well, how can we change that way of thinking? How can we start embedding it in the curriculum? And I think that's what we've been trying to do in Nottingham Medical School, where I support the undergraduate medical program in psychiatry. I think we've tried to make sure that awareness of not just about the mental health of our patients, but awareness of our own mental health and well-being is embedded in our training program. And that's what also I've tried to do in the international programs that I've been involved in. And this is the University Teaching Hospital in Lusaka in Zambia. And so, like I said, I think for me, I think the whole issue is that when we think about how do we make the best clinical decision, there are 3 elements there. So one is about patients, their ideas, beliefs, and concerns and expectations. Clearly, we all want to follow evidence-based practice. But the third element is that individual clinical expertise. And I think that individual ourselves is often the forgotten bit. I think we forget the need to look after ourselves. We forget the need to empower ourselves and to feel empowered so that we can actually help our patients and use our expertise to help our patients. And it's been a real bugbear for me that while we wouldn't allow anyone to enter a building site without a hard hat, yet we expect that in a profession like medicine or more widely in healthcare. Now, I might be referring to doctors today a lot and then say medicine, but I think the issues are very relevant to all healthcare professionals. So if there are people from other allied healthcare professions in the room today, I think what I say is very much relevant to you as well. Though the data probably has been collected more and the research has probably been more available in the arena of undergraduate and postgraduate medical education. And so I feel that while we know that medicine will expose you to mortality, morbidity, and you will come across a whole range of distressing scenarios as a part of your working life, and so it's a working hazard. And yet I don't think that the equivalent of a hard hat has been built into our training. And so that's something I feel quite passionately and strongly about. And I think my involvement with Doctors in Distress is very much a manifestation of that. And I think what has happened as a consequence of that lack of early prevention and early resilience training is that most of us now, at the end of the working day, we feel like we're completely drained. And so my hope is to kind of, at the end of this talk, is to give you some pointers as to how do we move from that sense of being drained to feeling a bit more recharged. And I'm a marathon runner, and a couple of years ago, I ran the world's highest ultra marathon in Ladakh in the Himalayas. And for me, I think it's just a manifestation of the various kind of things that we need to do to keep ourselves well. So for me, it's running. For other people, it might be other pursuits, some within medicine, some maybe outside medicine. But I think it's important that we give ourselves time and space for that, because looking after ourselves is very, very, very vital, not just for ourselves, but for our patient care. And I think I'm going to illustrate that in the next few slides. I'm going to skip some of these slides. I think, but this is just to illustrate that lots of celebrities have come out in the open and talked about their mental health issues. So talking about mental health, I think, certainly has become a bit more easy. I think even probably a decade ago, there was a lot of stigma about mental health and anything to do with well-being. But I think things have changed now, and we've seen, celebrities like Stephen Fry and Deepika Padukone, who is a Bollywood actress, come and talk about their experience with mental illness. And I'm the dean of the Royal College of Psychiatrists, and we've run programs in the past, and we've highlighted that that the prevalence of mental illness is as high as 1 in 4. But I think what that 1 in 4 figure sometimes obscures is the fact that that figure is not true for everyone, and for some groups of population. So particularly, we know that those who are economically deprived, or those who have had early life trauma or disadvantage, for them the rate is higher than 1 in 4. And similarly, what's not often realized, that for medical professionals and healthcare professionals, the rate is higher than 1 in 4. So we are actually more vulnerable to mental illness and mental health problems than the general population. And so if you feel free to guess. I can't see your answers, unfortunately, in the text box, but if you feel up to it, do put your answers in the text box. So I think people don't realize that the risk of this mental health problem starts very early on. So it starts in the undergraduate medical world itself. So we find the prevalence of depression or depressive symptoms in medical students is quite high. We're talking of almost 1 in 3, so it's 27%. So it's quite a significant number of students who report this. And how does that compare to other students of similar age adults? So if you compare medical students to because we all know that leaving home after sixth form and going to university is a time of stress. It's a difficult time, and so it's a stressful time, and then that does have an impact on mental illness of all university going students. But is it that medical students are disproportionately affected? Yeah, the answer is yes. Actually, the rate in young adults of similar age is almost a third of that of medical students. So we know that medicine is a high stakes profession. It is a high intensity profession, high intensity occupation. There are high stakes exams regularly. The course is quite difficult. The amount of material that you have to absorb and retain is quite a lot. And all of that does have an impact on the way you perform. And then obviously you're also surrounded by people who have all done very well. So you are in a group where all of the people in that group are high achievers, and that also has consequences. So much so that the prevalence of suicidal ideation is also pretty high in medical students. Now, it's not super alarming, though. The figure can seem quite alarming. I mean, it just needs to be borne in mind that the prevalence of suicidal ideation in the general population is also around 5 to 10%. So it's a little bit higher, but still, I mean, something worth noting, that people who have increased access perhaps to means of self-harm and suicide are then having a higher rate and proportion of suicidal ideation. So I think something to bear in mind. I think I certainly point this out to all medical educators and healthcare educators. And we've seen this happen in the real world. So I don't know whether if you've seen this documentary on Victoria Derbyshire, talking about Sophie Spooner. And in fact, Sophie's father is one of the trustees with Doctors in Distress, and Sophie's mother is also very much involved in supporting medical professionals and their mental health. So they're very much aware that that this is a problem that needs to be addressed. And GMC ordered a review, asked Louis Appleby, who has led the confidential inquiries in suicides and homicides in the country for a long time. They asked him to look at medical professionals, and he reviewed the deaths of 38 professionals. And I think clearly, I think the fact that you are referred to the GMC becomes a significant factor. There are other factors like being an international medical graduate, or having a mental illness. So there are a certain certain set of risk factors that we know can predict the risk of suicide. And I think if we get better at identifying those risk factors and working with people earlier on, I think we can prevent this. But this is probably not confined to the UK alone. I think if you look at the figures in the US, it's almost one doctor a day, and this is just doctors. And if you start adding healthcare professionals, then the number is quite significant. So over the last 5 to 10 years, this has now been highlighted as a real problem that we need to deal with. Having said that, I find, and I think research shows that medical students who actually disclose mental illness still report that they don't get the amount of support they need. And so the answer to this question is a shocking over 80%. So over 80% of the medical students with mental illness do not get the kind of support they would want. And so basically they report that they just don't feel supported. Now that is a shocking figure. And I think that is something that we as a group of healthcare professionals, and there's some responsibility, I guess, on all of us who are in the healthcare profession to address. What is the percentage of medical students with a diagnosis of depression seeking help? Again, it is quite low, and which is particularly sad because the outcome rates of people who do seek help are very good. So we know that that if people actually seek help early enough, then you are seeing that the response rates are in the region of 70 to 80%, which is fantastic, I think. And that's just for depression and anxiety. But I think even when you include things like substance misuse, which doesn't always enjoy a very good prognosis and doesn't always enjoy very good response rates, you find that medics and medical students, when they have sought help early for the substance misuse problems, the response rates are touching 90% and over. So the real moral of the story here is that seek help early. Don't wait, don't delay. The earlier you identify the problem and the earlier you seek help, the more quickly you're likely to resolve it and then get back to normal working. And there are a whole set of reasons why people don't seek help early enough and don't disclose early. We know that that female students are more likely to disclose problems early. Graduate students and more older students are likely to do that. People who have had to take time off sick, so at the more of the severe end of mental illness. So there is some kind of a trend there, but there are many other factors that stop us from disclosing. And again, researchers have looked into this as to why do we not seek help. And I guess what I started off with is one of the main issues, that we see ourselves as help providers and not as help seekers. And I think that is a big barrier. There's almost that us and them wall that we erect between ourselves and our patients, that we are not the same as our patients. And the reality is that we are like our patients. We are not some different species. We come from the same population, and we reflect that, and we represent them, and we are them. And so the kind of problems that we see in the general population also occur in the medical world and in the medical population. But there's a fear that if you get the label of mental illness, then that gets you involved. You might be referred to the GMC, or you get referred for internal processes, there's a fear of stigma, there's a fear of discrimination, there's a fear that your colleagues will view you differently, and then your patients will view you differently. I think a lot of my colleagues who have sought help have said that they particularly worry about patients not wanting to be treated by somebody who has mental illness. And I don't dismiss all these concerns. I feel that these are real fears, but unless we confront them, unless we deal with them, not just at an individual level, but as a group, as a profession, we're not going to make progress. And so there are a whole lot of reasons. And I guess at some level, it's also a pessimistic view that somehow, what's the point in seeking help? It's not going to be. And I've had colleagues who've said this to me themselves, that was the point of seeking help. It's not going to make things better. I need to get out of it myself. I need to sort things out. And yet, I mean, we know that logically that's not correct. That if you need to fix your if you've got an electrical problem in the house, or if your dishwasher needs fixing, then you call the expert, right? You're not going to try and do it yourself. If there's something, if you want to travel from Birmingham to London, you don't say I need to walk there myself because I need to do it by myself. I don't need to rely on others. You know that it's far more sensible to take the train or the bus or the car. And yet, I think when it comes to mental health, we somehow feel that I need to do it by myself. I can't ask an expert. I can't seek help. And I think that delay in seeking help is what ends up causing problems a lot of the times. Like I've said, there's good evidence to show that the earlier you seek help, the better you're likely to get, and the more likely you're likely to get better. And all of this has an impact not just on your health, but it has an impact on the entire system. If you have people who are turning up to work but are not fully there, what's known as presenteeism, it affects the productivity at work. It affects the morale at work. Overall recruitment and retention rate gets affected. And we're certainly seeing that in the last decade, the number of doctors and healthcare professionals reporting stress and burnout has risen significantly. We are seeing more and more people now reporting mental illness and then taking time off because of mental illness. So I think these issues are relevant. And I put up this slide because this was an award we won for our program, which we've led in the undergraduate medical student education in Nottingham for over 13 years now. And basically the program is of involving patients in teaching. So we have a set of about 50 patient educators who come in and share their stories, but not just share their stories, they also are involved in training our students. So they give feedback to our students about how they should interview them, or how they should talk to patients, and how they should communicate with them. And we found that we've seen over the years that consistently this program gets the highest feedback of all the things that we do, not just in psychiatry, but in medicine. And I think the reason why it's so popular is because there's the direct contact with an individual and an individual story. And so now we've extended it to doctors with lived experience. So we invite doctors with lived experience to come and talk about their experience of having had mental illness while at work. And we found that the response to that has been stunning. People have been able to suddenly feel that they are able to share, that they do feel stressed at work, that they do feel that they're not cut out for medicine, that medicine is stressing them out, or the thought of turning up to work is filling them with anxiety and dread. And you are surprised to know that you're not alone. This is a feeling that's shared by many other professionals. In fact, my psychiatric trainees committee in the Royal College of Psychiatrists is running a series of podcasts called You're Not Alone. So do Google that and listen to that. I mean, they are a set of inspiring podcasts, and I think you'll find that resource quite helpful. And so this Dr. 1 in 4 program has been actually quite a revolutionary program. We've been trying to promote a culture where doctors and students feel empowered to ask for help earlier, and that we move away from the idea that somehow acknowledging your mental illness is a sign of professional weakness. And so our outcomes are fairly straightforward. We want people, first of all, to know that actually the incidence of mental illness in doctors is quite high. So you might think that as doctors we are immune, but the reality is the opposite. We, like I said right at the beginning, we are a bit more vulnerable than the general population. And we want our doctors and medical students to get that first-hand perspective, that, well, what does it mean to actually have mental illness? What do you do when your GPA asks you the question? What kind of forms do you fill in if you want to get help from your clinical director or your managing medical director? How do you deal with the awkwardness from colleagues? Because this is true, right? That talking about that mental illness is awkward, and people do not know how to approach you if you say that you're depressed or anxious. I think I had this issue, at the beginning of last year. I developed an ankle, a fairly severe ankle sprain. So I was on crutches, and while I was walking around the hospital corridors on my crutches, at least about 50 people would have stopped me and asked me, well, what happened? How are you doing? And just a couple of months earlier, I'd written to my team saying that, like, I'm feeling a bit upset because I've lost my mentor who died quite suddenly. And out of a team of 70, only 2 people responded. And I think that just shows that, and I'm sure a lot of you in the audience must have felt the same thing, that if you are exposed to someone's grief, someone's sadness, then you don't quite know what to say or how to say it. And yet, I think we are in the healthcare profession, right? We are trained to ask difficult questions. We are trained so that in the middle of the night, wherever you're working, you can ask a whole lot of difficult questions about people's personal lives, about their personal medical history, embarrassing questions about their sexual history, embarrassing questions about their mental health, embarrassing questions about their, whether you are smoking cannabis or other drugs. And we expect people to disclose all of that to us. So I think we know how to learn to do this. So I think having those awkward conversations at work with our colleagues is something we can get over. I think we can teach ourselves how to do it. And I want us to think about how do we do that. And I want us to think about how and where to access support. And I don't know whether you all in the audience today know where would you direct your colleagues or yourself, indeed, if you needed help. And I'm not sure whether we kind of always have that information. And yet help is available, and I will share some of those resources. So clearly, Doctors in Distress is one such resource. We conduct a whole group of programs for people who are in distress, and our motto is quite simple. Our mission is quite simple. We want to help reduce suicides within the medical profession. The charity was founded by Amandeep, who lost his brother, a cardiologist, who ended his life by suicide. And he was moved enough to try and set this up. And his story is so inspirational and so incredibly humbling. And I feel there's always that little bit that we can do. I think, well, supporting charities financially is one thing, but also contribute with our time and energy and resource. But we're not the only one. There's Doctor Support Network, which is a peer support for UK-based medics who have undergone mental health problems themselves. People might have heard of Wounded Healer, Ahmed Ankir, Caroline Walker, who runs the Joyful Doctor and also runs the Tea and Empathy group on Facebook. So there are a whole lot of informal and formal support mechanisms. But if you are in work or training, make sure you tell your training supervisor, your clinical or your educational supervisor. Your deanery will have a professional support unit, and they can help. Your employer, your trust or health board will have some kind of a support for their employers. BMA offers support, and then there are the generic supports, and we shouldn't forget them. So there is across the country, there is integrated access to psychological therapy, so counseling services that are available through your GP, but also directly you can refer to them yourself. So if you Google IAPT, that's integrated access to psychological therapy in your area, you can access that. For doctors in England and Wales, we have the practitioner health program, and then there are similar programs in Wales and Scotland, though not in Northern Ireland at the moment, but most of the places have them. My own college, psychiatry, Royal College Psychiatrists, we run the psychiatrist support service, and there are similar services run by surgeons. And then there are other support programs for doctors with substance misuse problems, for doctors who have been suspended. So irrespective of where you are in your training or what grade you are or what kind of problem you have, you will find that there is an avenue of support. And I think what we find is that if you do actually seek the support, then the outcomes are much better. So I want to end on this note by saying that we are all in this together, and then together we can wipe out the stigma surrounding mental health. And I'll just briefly tell you the story. And I don't know whether you all have heard the story. This is from Professor Steve Robson, who became the president of the Royal College of Obstetrics and Gynecologists in Australia and New Zealand. And they've been running Australia and New Zealand to address this problem that I've been talking about. They've been running a program called Crazy Socks Day, where doctors wear crazy socks and just highlight that doctors have mental health problems too. And to support that, Steve Robson wrote a little blog talking about his story, about how when he was a trainee, he tried to kill himself. And he talked about how the only reason why he'd stopped was because some person he didn't know who, came in and knocked on the door and say, "I know you are in there," and just that intervention stopped them from killing themselves. And now they were the president of this college. And amazingly, Dr. Kate Tree read the story and then responded saying that, "Look, Steve, I had no idea that it was you, and then that you had thought it was you, that you thought that it was just plain good luck, and that we knew what was going on with you, but we just didn't know how to intervene, how to help, and that I hope I would do better now." And I think that's my message to you, that let us not shy away from intervening. If you see a colleague in distress, go and help. Offer something. If you yourself are in distress, then seek help. And so my take-home points are that remember that there is this continuum of well-being. Some of us will be stressed, but some of us will be having severe mental illness. And I think severe mental illness can actually be quite, damaging to one's health, and occasionally can lead to death. And so we need to take it seriously. But let's not underestimate the power of conversations. We can intervene, we can reach out, and as colleagues, we can be human. You don't have to be a psychiatrist or a trained professional to just reach out to someone else, just as one human being would do to another, and then ask out for them, saying, "Well, how are you? I mean, would you like to have a cup of tea? Would you like to talk about how you're feeling?" And finally, just make sure you know where and how you would seek help, and program it in your phone so that I've listed quite a lot of resources. They are available to you. So make sure you use them, and they are available to you very easily. So I'm going to stop there. You've got my contact details there, and for doctors in distress. And it's a charity, like I said, it relies on people's donations, etc. So feel free to go and visit the page and connect with us and support the charity. Thank you.
Thank you very much for your presentation. I certainly really enjoyed listening in.
I don't think I see any questions in the chat box, so
No, nor do I. So I think we can end the session here.
take care.
Thank you very much again.